Dear ELPA friends, today is Global PSC Day, and I want to dedicate my first thoughts to all liver patients that are fighting against rare diseases. These diseases are underfunded, rare, and often complex, with huge unmet social and medical needs, just like its PSC. I'm honored to welcome all the speakers today because only working together, creating networks, and generating and disseminating reliable knowledge, we can make fundamental changes to patients' lives. As a patient association, we are responsible for incorporating patient advocacy voices in each decision about us, and I'm extremely proud of seeing today so many people from all around the world to fight together.
As the leader of the Working Group for Rare Diseases in ELPA, I would like to welcome all of you, the leading physicians from various countries participating around the world, my friends and colleagues from all the major PSC support groups that have invested time and effort to make themselves available at all hours of the day and night to make this happen, and last but not least, my fellow PSCers and their families. Today is the first Global PSC Awareness Day and the start of something new, which will bring us closer to finding a cure for PSC, as working together makes us stronger. Today, you will hear about information concerning many aspects of PSC and the clinical trials that exist today, and there are quite a few that will begin in the near future. When you hear about these today, you will understand there are real reasons for hope. We may have a rare disease, but we are an enormous family of PSCers helping one another along our journeys, learning to live alongside our illness and fulfilling lives with the best quality of life possible. One of the most important things to remember is that there is lots of hope for a better and brighter future with possibilities of medications to help improve our quality of life and hopefully a cure in the not too distant future. I want to say a huge thank you to all the members of all the organizations for helping my dream of seeing us all working together finally coming true, and on to bigger and better things in the years to come. Now for the first presentation is Dr. Palak Trivedi, who will be speaking about the epidemiology of PSC and the impact on healthcare services. Thank you. Have a great day.
Thank you for inviting me to talk today and on this very important day, PSC Day. I'm going to talk briefly about the epidemiology of PSC and how it is sort of impacting our healthcare services, not just here in the United Kingdom where I'm based, but also more globally. So when people are diagnosed with PSC, or when healthcare professionals make that diagnosis, one of the first messages that are conveyed are about how rare it is. But what do we mean by that? So if we look at the incidence, that is the number of new cases of PSC, newly diagnosed people for every 100,000 people in the population, it varies depending on where you live to 0.1 to 4.4 per 100,000 individuals. There are some studies which indicate a slightly higher incidence rate, up to 6 per 100,000, but that's the sort of broad range that we're talking about here. The prevalence, that means the people who have already been diagnosed and are living with the disease, is also indicated on screen, and that's a much larger range. And I'll talk about some of the factors that explain that variability. By contrast, hepatitis C virus infection, which is one of the commonest causes of chronic liver disease in the world, is magnitudes greater in terms of its prevalence across the world, particularly in the West, but also in countries such as Egypt and the Far East, where we see even higher numbers. And we don't know why people get PSC, neither do we know why people develop other autoimmune conditions. But we do recognize certain common themes emerge. Now, the reason I illustrate this infographic here is just to highlight sort of not so much what we do understand, but also more so what we do not understand about the contributing factors. Thus far, despite a wealth of effort, there is not a single cause as to why people develop PSC, but we recognize that there are some genetic predisposing factors and certain environmental determinants. Now, the main environmental determinant that we've identified is that PSC invariably is a condition that is commoner in non-smokers. And we recognize that the genetic signals of PSC point to it being an autoimmune disease. And when we look at the different types of genetic signals in PSC, so these are gene variants that occur more commonly in people who have PSC compared to the general population who don't have evidence of liver disease or bowel disease. Many of them indicate that there are some problems with the mucosal immune system. So that's the immune system that helps control responses in the gut to our bacteria, to our fungi, to viruses that live there. There are some aberrant, some abnormal immune responses that occur to healthy gut microbes. And equally, there are some gut microbes that are there to a greater degree in people with PSC that shouldn't be there compared to other individuals. One of the questions that we're often asked in our clinic is about the risk to family members. And certainly when we look at the genetics, that only really explains less than 10% of the reasons why people get PSC. So despite the wealth of genetic work that we've done, we can only really explain PSC in relation to its genetics in about 10% of people. Now, that does not mean that there is no risk to associated family. There certainly is a risk. And one of the sort of landmark studies to highlight this comes from my colleague Annika Bergquist, who you'll hear from later on, looking at the risk amongst first-degree relatives. So that is brothers and sisters, parents and children. So if you're an individual with PSC, then a first-degree relative has an 11-fold risk, or sort of compared to the general population, your next door neighbor or sort of your work colleagues. They have an 11-fold risk of developing PSC themselves, and a risk that's more than 3 times greater of developing inflammatory bowel disease compared to somebody who is not related to you. The risk of either developing PSC or inflammatory bowel disease, if you have PSC only and no inflammatory bowel disease, is a little less. It's about 7.4, but nevertheless greater than somebody who is not related. So there certainly is a greater risk of developing PSC in your family members, but it's not absolute. Now, this is a busy slide, and my intention of presenting it to you is to show across the world the incidence, that is newly diagnosed cases of PSC sort of per year, per 100,000 population. It varies widely depending on where you look. We certainly see the highest cases, newly diagnosed cases, in the Northern Hemisphere, particularly Scandinavian countries. And we see much lower incidences of PSC in more Mediterranean climates, like in Italy, for example. We see much lower incidences of PSC in states of in North America, like California, compared to, say, sort of states in Canada. And the similar patterns is observed when we look at prevalence, when we look at the people who already have the disease and are living with PSC. Much higher rates in Scandinavian countries, much higher rates in some of the colder states of in the US, like Minnesota, compared to sort of more temperate climates. Now, most of these studies have been conducted in Europe, which I'm going to focus on in particular for the next half of the talk. And when you look at new diagnosis and people living with PSC, you can see that these cases are rising over the course of time. So we are seeing more and more people diagnosed with PSC than we did earlier on. Now, that might be due to the fact that our diagnostic capabilities have been enhanced. It may be because of increased awareness of the condition. But one of the questions that was asked when we look at this data is, what does it look like when we compare with inflammatory bowel disease? So many of you will also have inflammatory bowel disease, either ulcerative colitis or Crohn's disease, and have asked, is the reason for PSC increasing because inflammatory bowel disease is increasing? So we did a study last year looking sort of across the whole of England, so not the whole of the UK, but certainly England as a standalone country, and that was mainly because of data access requirements. And what we saw was that actually parts of England, so we're a small country, but we could still see parts of England where inflammatory bowel disease cases were most commonly being diagnosed year on year differed to the parts of England where primary sclerosing cholangitis was being diagnosed. Now, this may suggest that there are different risk factors and that PSC with inflammatory bowel disease is very different to inflammatory bowel disease alone. But remember that lots of people who develop PSC don't get diagnosed with inflammatory bowel disease at the same time, and vice versa. So we're still learning a lot about this. One of the other things that we found, so on the left-hand side, you'll see different types of inflammatory bowel disease over time. The rates of newly diagnosed inflammatory bowel disease, the lines are relatively smooth, relatively flat, not completely, but certainly it appears that inflammatory bowel disease incidence, new cases, has not really changed over a 10-year period. But by comparison, and yes, the scale bars are different because PSC is rarer than inflammatory bowel disease, but you can see that there is certainly an increase in primary sclerosing cholangitis with the inflammatory bowel disease types associated with it, which we don't see in people with inflammatory bowel disease alone. Now, one of my colleagues who works in Cambridge, Dr. Gwilym Webb, looked at all the listings for liver transplantation in primary sclerosing cholangitis, as well as other immune-mediated liver diseases. And what he showed sort of over the duration of that 20-year study period was that certainly PSC, so that's the sort of the dashed line in the middle there, the listings for PSC and for autoimmune hepatitis seem to be increasing year on year in comparison to, in this case, primary biliary cholangitis. So we're certainly listing a lot more people for transplantation with PSC. And when you look at data sort of elsewhere in Europe, so, you know, I like to show this Scandinavian example here. In the Nordic liver transplant program, transplantations, the number is going up year on year on year. And actually, PSC is the commonest indication for liver transplantation, despite it being a rare disease. Now, this really highlights not just the impact on healthcare service, but drives home the message. We do need effective treatments that slow down the rate at which liver disease is progressing in PSC. Otherwise, all we're going to be doing is transplantation. Now, transplantation is an excellent treatment for PSC, but we do, you know, what we want to see is medical therapy so people don't need to have it. The French group presented a similar study last year. Now, I don't expect people to sort of dissect this figure in detail, but just see at the bottom, these blue bars running across the bottom are the proportion of total transplants performed for PSC. And when we try to forecast over the course of time, by 2025, the majority of transplants in France sort of are going to be, you know, according to single indication, will be for PSC. So we're seeing this across the UK, we're seeing this across Scandinavian countries, and in France, transplantations for PSC are increasing. Coming back to England now, one of the things that we did in our epidemiology study was to look at the risk of other factors compared to inflammatory bowel disease, other clinical events. And on the bottom here, you know, we've got what we call the HR, the hazard ratio, which is a measure of risk. The greater the number, the greater the risk. And no matter which of these clinical events you look for, whether it's death, the need for bowel surgery, development of bowel cancer, bile duct cancer, pancreatic cancer, liver cancer, so hepatocellular carcinoma, gallbladder cancer, or a need for removal of gallbladder, so that's gallbladder surgery, the risk is greater than 1 for each of these, and is greater in people with PSC compared to those with inflammatory bowel disease alone. So we're seeing more and more of these procedures in people with PSC than we're seeing in inflammatory bowel disease, despite it being a much rarer disease. And what are the reasons why we're doing bowel surgery? So on the left-hand side here, in red, you can see bowel surgeries performed in people with PSC as well as with IBD alone. And you can look at bowel surgery according to red for colorectal cancer and dark blue for non-colorectal cancer indications. So that is bowel surgery performed because the colitis is still very active. And you can see here that the main indication for performing bowel surgery in people with PSC is because inflammatory bowel disease activity is not controlled. And that is the case across all age groups. So we do need better inflammatory bowel disease treatment pathways as well as for PSC. And when you look at the type of clinical events according to age, it is our younger people diagnosed with PSC that liver transplants and liver-related deaths seem to sort of form the most clinical events. And in older age groups, non-PSC related illnesses tend to predominate. So PSC as a condition, it's important across all age groups, but particularly younger people. That's where we really need sort of excellent treatments for, because we have much greater life years to get out of these people's livers. These are the people where PSC is making the most dent in their quality of life and quantity of life. But what can we what are the positives? What can we do? So I mentioned that there's not that many treatments for PSC. In fact, there are no licensed medical therapies at the moment, but many of you with inflammatory bowel disease undergo annual colonoscopy. And that's because at a young age, there is a high risk of bowel cancer. But when we look at the group of people who undergo surveillance, the risk of death from bowel cancer is much lower in people who undergo surveillance colonoscopy compared to groups of people who don't undergo surveillance. So it drives home the message that surveillance is changing outcomes. And just as in the last couple of slides to finish off, we are starting to learn that men and women with PSC have differences. Women with PSC tend to be diagnosed at an older age, more commonly with Crohn's disease, and with variant phenotypes, small duct PSC or PSC with overlapping features of autoimmune hepatitis. And thankfully in women, the risks of transplantation and PSC-related deaths are about 25% lower than we see in men. But please don't forget, ladies and gentlemen, inflammatory bowel disease can manifest before your PSC, at the same time, or after. And about 40% of people are diagnosed with inflammatory bowel disease after PSC first manifest. So that's why it's important to keep an eye on symptoms. And if your doctor advises you to undergo a colonoscopy many years after your PSC diagnosis, there is a reason for it. And finally, just to finish off, many of you undergo surveillance scans, ultrasounds, MRI scans. These are making a difference. We know, just like with colonoscopy, those people who undergo surveillance, for bile duct cancers, pancreatic cancers, have a much better survival in the event cancer is diagnosed than those people who do not undergo surveillance. So the incidence of death from cancers is lower in people who undergo scanning. So that is something that we've learned from epidemiology studies, and that surveillance is important. So thank you for your attention. It is not all doom and gloom, because there are some excellent treatment trials on the horizon, which we'll hear about later on. And, and I'm not going to labor about the mechanisms of actions of these drugs, but they are tackling multiple different pathways of PSC. And it is certainly a very intriguing time to be researching PSC. And I hope that you will continue to work with us. And we look forward to working with you, not just on PSC Day, but in the future. Thank you.
Hello, everyone. First, I'd like to thank you for the opportunity to speak to you today. My name is Annika Bergqvist. I'm a senior consultant at the Karolinska University Hospital, and I've been asked to speak to you about PSC and cancer risk. I'm well aware of that this subject is a subject that could create a lot of worry and anxiety among people with PSC, but I believe that knowledge gives security. So therefore, I would like to bring to you an update on what evidence of the risk and how cancer can be ruled out and investigated in people with PSC. I would say that if you go into the internet, you get a picture of the cancer risk that is over-exaggerated, and this is what I'm trying to show to you today. And I start off by using some questions that I usually get from my patients in the outpatient clinic, and that the most common ones are: how risk is my risk for cancer? How can the cancer risk be reduced? And what investigations is needed to be done when a cancer is suspected? And if I do get cancer, what are my treatment options? And how can it be detected at an early stage to enable cure? And where can I get support when I have questions? So cancer in PSC is located at places where chronic inflammation is present. First, in the liver, in the gallbladder, the liver parenchyma, but the major is in the bile ducts. Also, if you have an inflammatory bowel disease, you have an increased risk of colorectal cancer or dysplasia, and I will briefly also comment on that. So how high is the risk for cancer in the liver? Well, first I would like to say that the risk for bile duct cancer, and I focus on that, is highest the first year after PSC diagnosis. And this is due to the fact that the concurrent cancer in PSC is diagnosed at the same time or very close to each other. Therefore, in newly diagnosed people, a diagnostic workup with a high quality MRI with contrast is required. And there are such recommendations out there for your physicians that needs to be done. But after the 1 to 2 years after the diagnosis, when tumor has been ruled out, the risk for hepatobiliary malignancy is actually very low, less than 0.5% per year, and that is data from population-based studies. And there are, of course, factors that increase and decrease the risk. And the recent PSC diagnosis I just commented on, the presence of dominant or very tight stricture in the bile ducts are the locus for malignancy, and such strictures are increasing the risk. And also the risk increases with age, and that is the truth for most of the tumors at all locations in the body. So on the other hand, if you don't have dominant strictures, the risk is lower. And also if you have small duct PSC, the risk is close to zero for bile duct cancer. For gallbladder cancer, early detection of polyps is important because the cancer develops from polyps, and that is easily detected by ultrasound, and the polyps need to be removed. And also for liver parenchyma carcinoma cirrhosis is risk factors. So if you don't have developed cirrhosis, the risk for hepatocellular carcinoma is very, very, very low. So how is the risk for cancer in the large bowel then? Well, there is an increased risk here as compared to the general population. And again, a diagnostic workup at your PSC diagnosis is important. And the studies there are compares the risk between people with inflammatory bowel disease and PSC with concurrent IBD. And in that case, the risk increase compared to IBD patients are 3 times higher. And the risk is minimum or comparable to the general population when you don't have an inflammatory bowel disease. And one study in a population-based setting showed that after 20 years of follow-up, 7% developed colorectal cancer or dysplasia that needed intervention with colonoscopy, which is about 1.3% per year. So are there ways to reduce the cancer risk? Well, for colorectal cancer, of course, a good inflammatory control is very important, and the use of anti-inflammatory drugs such as 5-ASA is recommended. Another thing is to be don't miss the appointments for scanning of the liver and colonoscopy, and also always contact your doctor if you get new symptoms. Maybe they need to be investigated, maybe they're not associated tumors at all, but that is an important message to you all. So what investigations is needed to be done, and when is the cancer suspected? Well, if you do a scan and you have new or progressive strictures that are tight in the biliary tree, whether you have symptoms or not, when that is detected, you need it to be further investigated. I would like to stress that these strictures are benign in 90 to 95% of all cases. So there is a much higher likelihood to turn out with a benign outcome than that you actually have dysplasia or tumor there. And there are three things that is the base for such an investigation. That is high quality MRI, ERCP, and endoscopy with biopsies. And I will show you some examples now. This is an MRI where you can see the biliary tree and his little bile duct, and here you can see a tight stricture, and here a little higher up in the liver there is a dark thing here, which also is a stricture. These strictures have been progressing in this person and therefore further investigated. So there is an ERCP, which is an endoscopic procedure that is done in anesthesia. And you put the endoscope through the mouth of the patient, coming down here, looking at the papilla, and through this route you can sample, you can do brushing, you can also do endoscopies here. And this is the kind of brush used, and you put it up in the bile duct, and you get cells out. These cells can be affected by inflammation, chronic inflammation, which makes it difficult to separate between benign or potential dysplastic cells. Therefore, often an additional investigation is performed by the pathologist or cytologist, looking at the DNA content or genetic expression of the tumors, which can help us to rule out or detect dysplasia. Sometimes at the same time or sometimes sequentially, a cholangioscopy is performed. And this is pictures from inside the bile duct. And here you can see a normal bile duct, but here you can see an inflamed bile duct. And in this case, you can take biopsies, and then you get out even more cells to evaluate. After all of this is done, when you have a new progressive strictures, the best way of doing it is to have a multidisciplinary team conference with all the specialities coming together. Here, we look at your performance, the patient's general condition, lab samples, radiology, results from the ERCP, and all together this is serves to get the recommendation whether tumor needs to be further investigated, operation, or in most cases just an ordinary follow-up. So if this unlikely setting is happening, that you actually have dysplasia or tumors, what can be done? Well, for colorectal cancer, surgery is the base. That could be done with or without chemotherapy, but if you have just small and early lesions, the surgery is enough. That is also true for the polyp situation, and for bile duct cancer or hepatocellular carcinoma, the surgery is a bit more extensive, and you can be cured, have a potential cure by surgical resection or liver transplantation. The choice here often depends on the severity of your underlying liver disease. So how can we detect tumor at an early stage, which is very important? Well, actually, the answer is we don't know. So there are many strategies out there, and this is data from a large survey that we did around in the world from centers, and I would say that there are nearly as many strategies as there were centers. but mainly regular scanning at different intervals are used, and that has been associated in studies with better outcome. However, the evidence is not very strong. But there are two things important doing the regular scanning. One is the early detection of malignancies, but the other one, and maybe more important, is to detect benign treatable strictures that are very tight. And by treating them with the ERCP, we could possibly save liver parenchyma and prolong the need of the time to liver transplantation. These are tricky questions, and the cancer diagnostics is very, very difficult. So both patients and physicians might need support. As a patient, you should always require from your physician both to have an individual risk assessment, but also to have the support and information that there is. Also, of course, patients supporting groups and organizations is important, but there is also another way of getting support, both for physicians and patients actually, and that is through the European Reference Network, Rare Liver. This is a Europe-wide network for centers of excellence in the clinical management of rare liver disease, where PSC is one of them, of course. And the aim is to improve the standards of clinical knowledge and of patient care in Europe. And I am the lead of the working group of PSC, and we are currently working on bringing out information to patients. You can look more on the home page, and there is also a place where difficult situations can be discussed between physicians here. So please go to the homepage and look at many translated patient information leaflets there. So in summary, and the take-home message is that people with PSC have a high risk for cancer compared to the general population, both in the liver and gut, if IBD is present. 30 to 50% will develop tight dominant strictures that needs to be further investigated and treated and to rule out malignancies. But the chance that the biliary dominant stricture is benign is very, very high. And early detection enables curative treatment. However, we must admit that we haven't solved the problem as yet, and more research is needed, both for cancer prevention and tumor treatment. And thereby, I would like to thank you for your attention.
Hello, everyone. My name is Dr. Udi Zygmunt, and I'm from the Center of Autoimmune Liver Diseases in Tel Aviv Medical Center. And today I will talk to you about emerging therapies in PSC. So first, let's talk about the challenges in PSC clinical trials. So first, as you know, PSC is a rare disease, and thus there are not so many patients, and we lack statistical power in many of the trials. Second, the PSC progress relatively slow, and thus we have low event rates. So studies have to go on for a long time, sometimes more than 2 years, in order to show significant results. Another point is that the disease has a variable natural course. The disease also fluctuates with symptoms and with laboratory tests. And we have a lack of surrogate biomarkers. All of this makes and PSC trials very challenging. So about what we have. So to date, unfortunately, there is no medical therapy which is proven to show significant impact on clinical outcomes in PSC. However, many patients are treated with UDCA or URSO or URSOLIT, and the early studies regarding these drugs showed improved markers of cholestasis, such as alkaline phosphatase, ALP, and also a trend for better outcome. Another interesting study showed that patients where they withdraw UDCA therapy, there was a deterioration in liver biochemistry, alkaline phosphatase, other enzymes like GGT and bilirubin, and also emerging of pruritus. Important to note that one trial that used high doses of UDCA had worst prognosis in the treating arms, and thus high dose of UDCA should be avoided. In summary, UDCA failed to show effect on transplant-free survival, okay, the chance of liver transplantation or death, and there is still controversy regarding the benefits of this drug in PSC. The EASL guidelines summarize that the limited database does not yet allow a specific recommendation for the general use of UDCA in PSC, and thus this is the decision of the treating physician together with the patient. However, the good news is that in recent year, we have lots of study of research in PSC, and thus we have and the translation of this is that we have a lot of emerging clinical trials starting in recent years, and these new drugs try to improve parameters of the disease via different mechanisms, including bile acid-based therapies, microbiota-based, and also immune modulation therapies. So the first compound which I want to mention is norursodeoxychic acid, or norurso. This drug is a synthetic side chain, shortened side chain of UDCA derivate, and it's resistant to amidation, and it undergoes cholehepatic shunting, meaning it's going again and again inside the liver, getting high concentration inside the liver, and not like UDCA, it is secreted into the bile as unconjugated form, and also not like UDCA, its metabolite does not accumulate in hepatocytes or cause hepatotoxicity. And it has several mechanisms that are beneficial in cholestatic liver diseases. And the phase 2 study was already published in 2017, and this study used different doses of NOR-UDCA, and it showed a dose-dependent effect on reduction of alkaline phosphatase level up to 12 weeks of the study. Importantly, there was no differences in pruritus between the treating group and the placebo group, and the safety profile was excellent. So currently, Dr. Falk, the company that make this compound, this drug, are doing an ongoing phase 3 trial in many countries. In this study, there are groups that are treated with 1500 milligram per day of norurso versus placebo for about 2 years. And the aims of this study is to show superiority of norurso compared to placebo. They want to show prevention of disease progression by following serum levels of alkaline phosphatase and also liver histology. So hopefully we will have results of this trial in about a year. Another group of drugs that are very, very interesting are the FXR agonists, or drugs that works on the receptor which is called FXR. FXR is expressed in the gut and in the liver, and it has a many beneficial effect on cholestatic liver diseases. It has a choleratic effect. It means it decreases bile acid synthetic, decreases absorption of bile acid, etc. And it also has anti-inflammatory effect and possibly anti-fibrotic effect. FXR, when it's activated in the gut, it released a compound, a chemokine that, or hormone known as FGF19, which also works on the liver and has some beneficial effect. So the first known steroidal FXR agonist is obeticholic acid, and this drug is known as Ocaliva, is already approved in the US and in Europe for the treatment of primary biliary cholangitis. Regarding PSC, there was a trial, the ESOP trial, that was published in Journal of Hepatology in 2020 that showed a reduction of alkaline phosphatase of about 25% in the group that were treated with the higher dose. The results were sustained for 2 years of the long-term extension phase, but there was a side effect of pruritus that was dose-dependent. So far, a phase 3 trial with this drug, as far as I know, has not been started yet. So this is the Ocaliva, the FXR agonist, which is steroidal, but many pharmaceutical companies try to develop other FXR agonists, which are mainly non-steroidal, hopefully with less side effect and hopefully maybe even more potent. So one of them, of these drugs, is made by Gilead, and it's known as the cilofexor. Cilofexor was tested in a phase 2 trial in PSC. It was published in 2019. And they found that in the treatment arm that received 100 milligram per day, there was a decrease of about 20% in alkaline phosphatase. The drug was safe, and there was no sign of pruritus. So currently, the PREMIS trial is a phase 3 trial of this compound, cilofexor, and the primary outcome is the proportion of patients with progression of liver fibrosis at week 96, meaning about 2-year trial. This trial is ongoing. However, the recruitment is already closed, and about 400 patients were recruited, about 2/3 for the treating arm group and about 1/3 for the placebo. And we hope to get the results in about 2 years. Another interesting compound is aldafermin, known as NGM282. This is a first-in-class analog of the endocrine hormone FGF19, which I've mentioned. It was tested in a phase 2 trial that was published in 2018. However, the primary endpoint of decreasing alkaline phosphatase was not met. They did find other endpoints which were improved, like hepatic injury and fibrosis that was assessed by several markers, and there was improvement in other liver enzymes like ALT and AST in this with this drug. This finding challenged the dogma about what is the appropriate endpoint that should be in trials in PSC. Should it be alkaline phosphatase, or maybe we should also look at different or other markers as well. So what about the gut microbiota? As you know, in the Western world, most of the patients with PSC also are diagnosed with inflammatory bowel disease. And there is a lot of research about this interaction and maybe substances like bacteria or bacterial products that comes from the gut into the liver and start or aggravate the disease. So many antibiotics were tried in PSC but the most prominent, most emphasis currently is on vancomycin. which is kind of gut selective because when it's taken per oral, it does not absorb into the body. First, there were several case series and small randomized trials that showed improvement in liver enzymes. However, a more recent trial from 2018 of the Registry of Pediatric PSC Consortium showed that there was no significant difference in liver-related outcome. However, I believe it's not the final word regarding gut microbiota targeting therapy and also vancomycin. There are several, in summary, we can say that there are several promising efficacy signals with this drug, and further studies are needed to clarify the mechanism. We also should be maybe concerned about promotion of antimicrobial resistance and think about it. And currently, the recommendation is that antibiotics prescription in PSC should only be performed in the context of clinical trials. Happily, a new trial, a prospective trial with vancomycin is now recruiting in the US in the Mayo Clinic. Their aim is to find out if vancomycin is safe and effective therapy, and they plan to recruit about 120 PSC patients and to follow serum alkaline phosphatase, liver fibrosis with FibroScan is a type liver stiffness measurement, non-invasive way to assess liver fibrosis with a special ultrasound, and also to look at the changes in intestinal microbiota and in pro-inflammatory cytokine. What about other drugs? So fibrates are really interesting recently. They work as a PPAR agonist, and they have several anti-cholestatic effects like enhancement of biliary phospholipid secretion, inhibition of bile acid synthesis, and upregulation of bile acid detoxification. So this bezafibrate was assessed for the treatment of pruritus in PBC and PSC, and it's shown to be very effective to treat pruritus, but also showed a very nice improvement in alkaline phosphatase. It was a 35% reduction in alkaline phosphatase from baseline, and further studies should assess whether this drug is beneficial in the long term for PSC patients. There is lots of interest in pruritus, and one of the mechanism to try to solve this problem is with drugs that inhibit the absorption of bile acid from the ileum, from the gut back into the blood system. And one of this drug is volixibat, which is oral minimally absorbed agent, which is inhibitor of this receptor in the gut. A similar drug was shown to be beneficial in children with cholestatic liver disease, and also to improve overall disease in these children. So currently there is recruitment for a trial in PSC to treat pruritus, overall 120 patients, 2 different doses, and they will look at pruritus, but also as an additional endpoint on fibrosis marker, and we will see what happened with this trial. Another compound from Escient is a specific compound that acts on a G protein coupled receptor. It's a specific receptor expressed by neurons, which is responsible for pruritus. And the company in July this year announced that a positive result from phase 1, and they are now recruiting for a phase 2 for pruritus in PSC. I will just go very fast, briefly, on several compounds which are in more early phases. One of them is coming from an Israeli company known as Chemomab. This is a biological treatment. It's an antibody specific for a chemokine known as CCL24, which is a critical mediator in inflammation and fibrosis. Results in animal models are great, and they started a phase 2 trial with 5 infusions every 3 weeks in PSC patient in ratio of 2:1 versus placebo. And recruitment, and now they are recruited now in the UK, in Germany, in Spain, in the USA, and in Israel. This is another compound from a company named Pliant, which they made a dual selective inhibitor of integrins, which designed to be anti-fibrotic, and they have recently started also with a phase 2A trial. Another interesting direction comes from Orbsen Therapeutics, which work on mesenchymal stromal cells, which are derived from human umbilical cord. This compound, known as Orbcel, showed to be very effective in animal models of PSC. And now they are doing a phase 2A trial with an aim to find the appropriate dose and to show safety, tolerability, but also change in liver enzyme. So to conclude, in these days, we have a very active basic and clinical research in PSC. And as I showed you, several trials already in advanced phase 3 stages. And hopefully we will have a positive results in a year or 2. So I would like to thank you for your attention. Thank you very much.
Good morning. I am Joshua Korzenick. I'm the director of the Resnick Family Center for PSC Research, and I'm also the director of Brigham and Women's Crohn's and Colitis Center. This is at Brigham and Women's Hospital at Harvard Medical School. And we are busy in terms of both clinical care, taking care of about 4,500 people, and also very involved in research in inflammatory bowel disease and primary sclerosing cholangitis. And just as a word of introduction, I should say that most of my life I've spent investigating inflammatory bowel disease, and have more recently, our group has turned our attention to this interaction between the two and understanding primary sclerosing cholangitis, particularly with the idea of developing new therapies. So while we're trying to understand the microbiome, genetics, all these different aspects, it's really very much focused in on coming up with new therapies in the near term. And it's been interesting for me to understand how separate these worlds have been, the liver and the GI tract. And part of what we're hoping to do is take advantage of some of the wonderful research that's been done in inflammatory bowel disease and interact more with the liver world. And it was surprising to me when I started getting into this a number of years ago, how separate these worlds really have been. And I think that they both can learn a great deal from each other. And that's what I'll touch on just briefly today. So how do we approach PSC to really understand it, to develop new therapies? How do we go about doing this? Well, certainly one way that we do this is we look at the genetics, the microbial, the bacterial components, the environmental and clinical clues. And we'll talk a little bit about that today. But to understand, what we do is we will do, say, a time-intensive study to say, what's the risk of, say, coffee consumption? So how much coffee do you drink, and how does that influence the risk of developing primary sclerosing cholangitis, and how does it impact the disease course? Now, interestingly, there's some studies to suggest that coffee may reduce the risk of developing PSC and may impact on the disease course. It's a very modest association. It's important to do these studies, but when we do all these various studies and we look at all of these things, whether it's the genetic influence, which we'll talk about, whether it's these other things, really the thing that is most broadly staring us in our face is that 70 to 80% of people with PSC have IBD. So that's an enormously important clue. And that clearly tells us something. And that association, I think we need to look at in much more detail to appreciate how important that is and how important that can tell us really what happens with both diseases. And the approach that we are taking is that to understand PSC, we need to understand ulcerative colitis. And to understand ulcerative colitis, we need to understand PSC. Now, I'm not ignoring Crohn's disease, that's important as well. But the association that is strongest is with ulcerative colitis. And there's this important interaction, which is certainly well recognized and well appreciated, but not sufficiently understood in terms of how one informs the other. So how are they connected? Well, first, in terms of very basic things, about 3 to 5% of individuals with ulcerative colitis have primary sclerosing cholangitis. So that's a relatively small number. I think that when we look at the numbers globally of people who have ulcerative colitis, it probably means that we're very much underestimating the total number of people with PSC. And that's certainly the case in the United States. I think the numbers are far greater than what we state. And even in terms of the numbers that have ulcerative colitis in the United States, it was always said, well, maybe about 800,000 people have ulcerative colitis. Several years back, the CDC, the Center for Disease Control in the United States, suggested that might be twice that. And roughly an equivalent number at least in Europe. So the total numbers then for 3 to 5% are much greater than what the estimates are. But the critical thing, as mentioned, is 70 to 80% of people with PSC have ulcerative colitis. So that's a hugely important issue. And as many of you know, there is this important connection in your own life in terms of clinically what you're dealing with that is important in terms of just day-to-day life and how to handle things. It's slightly less with Crohn's disease, though some studies suggest similar rates. One study suggests as much as 7% with Crohn's disease, but I think most people feel that's a little bit of an outlier. And it's more, perhaps about 80% of those people who have IBD and PSC will have ulcerative colitis. About 15% of those with PSC and IBD, inflammatory bowel disease, will have Crohn's disease. And then about 5% have indeterminate colitis, meaning some elements look like ulcerative colitis, some elements look like Crohn's, but we can't really determine whether one is definitively Crohn's or ulcerative colitis. And we have this gray zone, which we leave as a little bit of both. Sometimes PSC can occur before IBD, but it's less often. And sometimes it can be a little bit more subclinical. And one of the critical issues is IBD, is ulcerative colitis with PSC the same disease as those who don't have PSC? And there's some controversy here. And perhaps there can be a milder presentation, meaning that there can be the same or even more inflammation when you look in with a colonoscopy, but someone might not have much symptoms. So anyone who's diagnosed with PSC, even if they have no GI issues, no GI symptoms, no intestinal symptoms, no diarrhea, no abdominal pain, those people should all have a colonoscopy to make sure they don't have inflammatory bowel disease, even in the absence of symptoms, because sometimes with PSC, it can be milder. And there are some clinical differences that are important. So sometimes it can be a little bit more right-sided disease. Sometimes the inflammation itself can be more severe, but these are fairly subtle differences. About 25% will have something called backwash ileitis. So ileitis, the ileum is the last part of the small bowel. And typically in ulcerative colitis, it's not involved. So you might have the whole colon involved, and with your colonoscope, you go into the small bowel, and then suddenly it looks healthy and pristine and fine. In PSC, there can be a little bit more of what we call backwash ileitis. So it looks like there's a little bit of inflammation in the last part of the small bowel. Now, sometimes people would say, oh, that must be Crohn's, because Crohn's involves the small bowel, ulcerative colitis doesn't. But this is something that can be a little bit more of a feature in PSC, but we also see that in perhaps as much as 10% of people who have pancolitis, so meaning the whole colon without PSC. So there's a subtle difference there, but it's not a determining factor that says, oh, this is clearly different. And about a third of people with PSC will have rectal sparing, meaning the rectum is not involved. Usually with ulcerative colitis, starts in the rectum, works its way back, but it's a little bit more common that there's rectal sparing. Now, this can sometimes happen with ulcerative colitis. Sometimes we think, is there something about Crohn's? But I wouldn't say that this means distinctly it's different. There's a greater risk of colon cancer. This isn't how it presents, but we will often start doing in the United States a colonoscopy after 8 to 10 years of disease, particularly for the whole colon involved. But if someone has PSC, at diagnosis, we start doing it every year and taking a good deal of biopsies, as much as 33 biopsies throughout the colon, to make sure there isn't any dysplasia or early findings of precancer that we would want to jump in. So that's an important element to understand. But that's, so when we do gene expression studies, meaning what proteins are expressed in the colon, so very detailed studies of what are the subtle differences between these, there are very minor differences. So meaning that on a protein level, on a very detailed level, we don't really see significant differences between the two diseases. There may be, meaning those who have ulcerative colitis with and without PSC. So even though many people will say, oh, there is a distinct type of disease, and it's really different, it should be a different disease altogether, I don't think that's the case. I think there are some differences, and we may understand better what some of the subtle differences are. And we'll talk about some of these things, but overall, I think it really is the same fundamental pathology, the same fundamental causes of disease that influence ulcerative colitis with and without inflammatory, with and without PSC. So I think that's really, really critical, because it involves then how are we going to treat and how are we going to understand these diseases. So one important question is, how does ulcerative colitis or Crohn's influence the outcomes in PSC? So if you have PSC, how does the disease, the IBD, influence what happens? So those with Crohn's tend to be more women, female, and those have a slightly slower, milder disease progression of PSC. And curiously, with ulcerative colitis, it tends to be more males and have a more severe disease progression. And it's an important distinction. It doesn't always hold true for an individual, but as a broad category, that tends to be the case. If somebody has a cancer or has refractory disease that's not responding to any medication and needs their colon out, it does not have a dramatic impact on PSC. There's some data to suggest a mild beneficial impact. It might moderate disease outcomes slightly, but it doesn't alter it in a fundamental way. Unlike, say, if somebody has joint pains that are associated with ulcerative colitis and you have a colectomy, usually that means the joint pains go away. But unfortunately, it doesn't have a big impact on PSC. Now, there's some impact, and there's clearly some association, but it's not the determining factor, and you get rid of the colon and everything is fine. So that's an important element to understand, and it might be that the colon causes some injury or some effect in the liver that then persists even once the colon is out. And those with PSC and ulcerative colitis also, though, have a higher risk of recurrent PSC after transplant than those without ulcerative colitis. So that's important because it reinforces the role of ulcerative colitis in stimulating PSC and in terms of trying to understand these diseases and what their interaction is. So when we look at things, how do we understand the environmental clues? We know that smokers have a lower risk of ulcerative colitis. We know that smokers have a lower risk of PSC. And that applies really to those who have ulcerative colitis and PSC. So if you have PSC without ulcerative colitis, there isn't much of an effect. Now it's curious in ulcerative colitis, if you quit smoking, your risk is higher than if you had never smoked. It's not just that it goes back to the background risk as if you had never smoked, it's higher than if you had never had it. Now that effect seems like there may be the benefit of smoking is slightly reduced in PSC. It's a little bit more confused in PSC and it's harder to understand. There's some interaction there, there's some effect, and certainly we're not recommending anyone smoke as a way of having a beneficial effect, but we're trying to understand why that is. And we're doing some studies now that we think may give us important clues and may give us important ways of treating the disease, not with nicotine, but in the ways that nicotine affects the body. We might be able to find other ways of treating PSC and ulcerative colitis and looking at that now. There's some data to suggest that both ulcerative colitis and Crohn's and possibly PSC the risk of developing those are increased with antibiotic use prior to the disease. Now, it may be a non-specific effect, meaning it's not the antibiotics that are directly affecting the liver, but it's changing the microbiome. It's changing your gut bacteria, it's restricting the diversity, and it's causing certain bacteria to be able to predominate, and that maybe is what leads to PSC and inflammatory bowel disease. Oral contraceptives are more controversial or more uncertain. It may decrease the risk in PSC in one study, and it may increase the risk of inflammatory bowel disease. It's much more uncertain, particularly with the newer low-dose oral contraceptives, so that may not be an important clue, and it may be misleading overall altogether. When we look at genetic clues, there are genes that have been identified that are important in association with PSC and inflammatory bowel disease. But many of these, it's not like you get a gene and you get the disease. So say in Crohn's, there's one that's been identified in perhaps as much as a third of patients with Crohn's. But it means in the United States that perhaps, say, this particular gene called autophagy happens in as much as, say, 35% of people with Crohn's, but it also happens in 25 to 30% of people without. So there is an important difference, but it might mean that there's, say, 120 million Americans who have this gene, but only perhaps 200, 300,000 have Crohn's in association with it. So these associations are important for understanding the pathophysiology and understanding the disease, but aren't all that important to understand the impact on an individual. And having that particular gene isn't a test to say you will or won't get it. There are overlapping genes in PSC and IBD. And even though the disease is rarer, it may be that that genetic influence is stronger in PSC than in IBD. But there's not a panel that we would say you should get tested. It's not clinically relevant. The risk of occurrence seems greater in ulcerative colitis, but, oops, there's a little typo here, but the genetic links appear stronger between Crohn's and PSC. We don't understand why that is. There are a lot of studies that others have done and we're doing as well to understand how the bacteria influence outcomes. And this may be a very, very critical component. It's something that all of the medical world is very excited now, both in terms of PSC, in terms of ulcerative colitis, in terms of Crohn's, in terms of other diseases as well, as sort of an unappreciated organ in the body that has important clues. There's an overlap to the shift in the type of microbial alterations that happen in PSC and UC that have some similarities, but there's also a distinct profile when we look at the colonic microbiome in people with PSC. Now, we first looked at just what bacteria are there. We're now trying to get to the next level where we're looking at what are they doing? And it's complicated because if we look at the gut flora, if we look at humans, we have maybe 30,000 or so genes. When we look at the colonic microbiome, there may be 2 million genes. So understanding that, sorting that out, using these advanced biologic techniques to understand is complicated. Now, how would the bacteria affect things? Well, we have our own theory that we're working on that leads directly to a particular therapy. But is there an increase in bacterial translocation, meaning are there certain bacteria that make the colon a little bit more leaky, and then some bacteria can translocate from the gut to the liver? Or is it just that it makes it so certain bacterial products are more able to get out of the colon and go to the liver? And there are a certain set of bacteria that seem to be implicated in PSC that may do that and may be important. And so is there a distinct subset that leads to this intestinal permeability? How do we look at the therapeutic clues? Well, the thing that's very frustrating and puzzling here is there's many medications that we use that have some benefit for Crohn's and ulcerative colitis, such as infliximab, or Remicade, adalimumab or Humira, vedolizumab or Entyvio, and other immune suppressants such as 6-MP or azathioprine, but those don't have an impact on PSC. So why is that? And that's a very, very frustrating area to understand, because it also tells us something very important. Sulfasalazine, which is the first mesalamine, or mesalazine as it's called often in Europe, may not have an impact, well, may have an impact on PSC. Mesalamine doesn't, but in two retrospective studies, our own and another, sulfasalazine can get to the liver in an active form. And we have a prospective trial that we're just about to look at the data that we've done here out of the Brigham to see if we're repurposing a drug. It's not used so often, it's more mesalamine, and we'll have a sense soon of whether this may be something of benefit to at least some people with PSC. Antibiotics are not effective in ulcerative colitis, and it's controversial if there's a benefit in PSC. And fecal transplant, taking stool from somebody who's healthy and giving it to somebody who has ulcerative colitis or PSC, it may have a benefit in ulcerative colitis. Our pilot study, though very small in PSC, showed a minor benefit in just 3 out of the 10 people. So it was done with an older technique, and there's still, I think we'll want to look at that again as how do you really change the microbiome? That's one way. Probiotics haven't been effective, so we're looking really at a more wholesale, intensive approach, and FMT hasn't really, so far in the early studies, haven't shown a benefit. So what are our steps forward? We need to have more crosstalk between those that research PSC and IBD, and that's going on now around the country here in the United States as well as in Europe. So I think that's going to be very productive and very exciting. We need to have a recognition that these two diseases are interconnected in a really fundamental way. We need to understand better what is the nature of that interaction. And we need to have an appreciation and understanding of why the medications that can help in ulcerative colitis don't help in PSC. What is distinct about the nature of the injury or the response to the injury that differs between the colon and the liver? Now, we've spoken a lot about sort of hypothetical things about research areas. All of our research is really directed very much at clinical understanding and clinical therapies. So we're trying to come up with new therapies. We've been looking at a dietary intervention, which we'll have results on quite soon in PSC. And we have a very new approach that we're going to start studying in the next, hopefully our first patient will start in January, with a very different approach to what this disease is and looking at the microbiome as well. And so we think bringing these two diseases will have a fundamental value, and we're tremendously excited. We're tremendously optimistic about the near-term future in terms of bringing therapies to people with PSC and really hoping to alter the outcomes in this disease in a fundamental way. So thank you very much for being part of this important day. And I look forward to working with the European Liver Patients Association, as well as other physicians and researchers. Thank you very much.
Hello, everyone. Thank you very much for the organizer that invited me to talk to you today. It's a real pleasure, and I think it's very important for you to gain some information regarding PSC. I see you as a very important partner for treating your kids or yourself. So thank you very much. So my task was to talk to you about some insights and some new things about PSC in children. So PSC in children is quite rare. You've heard before about PSC in adults, but PSC in children is more rare. It's about 3 new cases per million children annually. In the United States, it was there were about 250 cases a year, each year. Now, of course, as you know, PSC is more common in children with IBD. About 10% of children with ulcerative colitis have PSC, whereas if you look at PSC, you can see that most of the children, depending, of course, on the country and on the state, about 70 to 80% have IBD. So you've heard about PSC in adults. Well, I want to tell you the main differences between adults and children. So first and foremost, in children, we see more autoimmune sclerosing cholangitis, which is not quite as primary sclerosing cholangitis. What is autoimmune sclerosing cholangitis? It's actually a new entity, sort of new entity, which has been for a long time, but only in the past several years we referred it as a really discrete disease. It was once regarded as overlap syndrome, and how do we diagnose it? We diagnose it as having high titer of immunoglobulins and IgG, which I'm personally always happy to find that the child with PSC have autoimmune sclerosing cholangitis, because I can treat him. We can treat him with immune suppression, with steroids, with Imuran, and this actually presents better prognosis. So kids with sclerosing cholangitis, which is autoimmune, have better prognosis than just primary sclerosing cholangitis. So going back to the differences between adults and children, so autoimmune hepatitis and autoimmune sclerosing cholangitis is more, we see it more. We see less biliary strictures and complication than in adults. Maybe it comes later in years, but during childhood, we don't see it as much. We see less cholangiocarcinoma, which is a tumor in the bile duct system. We hardly see it in children, and later on in life, it's also less common. And overall, if you look at adults versus children, the prognosis is better in children than in adults. And finally, when looking at the blood test, alkaline phosphatase is an important marker for bile duct damage in adults, less in children. Why is that? Because alkaline phosphatase comes from bones, and children grow, and if they grow, the alkaline phosphatase rises. So it's not a good marker for bile duct damage in children, rather than just like in adults. But a good marker is gamma GT, which I'll talk about it in a few minutes. So up until now, we didn't have a lot of good data regarding PSC in children. There were a few case series, mostly small, mostly from single centers, and mostly were from transplant center, which actually presented more difficult cases than there actually are. So this actually precludes us from providing the families with good data. So the family knew less, we knew less, and there were also less endpoints for clinical trials and for studies in PSC in children. But thankfully, a few years ago, this has changed. So around 2015, several researchers from University of Utah in the US has formed a pediatric PSC consortium. It started about 700 patients, and now it includes more than 1,400 children from 50 centers in the world in 60 nations. So you can see here the centers scattered all around North America, mostly United States, and in Europe. Here's Israel, and some in the Far East. So this study and this consortium actually gave us, and still giving us, a lot of information regarding PSC in children. The first study, or the first paper that came out of this consortium, published just on 2017, and it summarized 781 children with PSC all around the world. Of course, now it's more kids, but this study and this paper was a pivotal paper that we learned from it a lot. I want to show you some of the data that came out of this paper, and one of the most important one is that there is a steady progression of PSC in children through the years. Usually at 5% of the kids are already symptomatic at the diagnosis, but the disease is progressing very slow, and by 10 years after diagnosis, about 40% of the kids have some symptoms related to the liver, meaning portal hypertension, varices, and maybe even end-stage liver disease. What about liver transplant? According to the cohort that we studied, after 10 years, only 30% of the kids undergo liver transplant. Actually, most of them already becoming adult when they need transplant. But this tells you that the disease is progressing, but some of the kids will, of course, need liver transplantation. But most of them actually survive without liver transplantation. What about treatment? So most of us 10 years ago or less than 10 years ago treated all children and adults with PSC with ursodiol or Osulit or also the oxycholic acid, which was used in most of the children. But a few years ago, there was some sign of toxicity and side effects, mostly in adults. So we stopped for a moment and thought whether this actually makes a difference treating kids with ursodiol. And this study actually showed us, this is the first slide I'm going to show you regarding ursodiol, is that if you look long term, there was no difference between children who were taking ursodiol or not taking ursodiol. But this is not the end of the story. So nowadays, until a few years ago, depending on the patient, depending on the doctor, not all of the kids received ursodiol. But this has changed like 2 years ago. Gamma GT, which I'll talk about in a minute, is one of the liver enzyme, one of the bile duct markers, has been shown in a study that we've done 2 years ago, published 3 years ago, that if it decreased significantly, then it's a good marker for good prognosis in the children. And just to remind you what is gamma GT or gamma glutamyl transferase, it's an enzyme which is in the bile duct. This is a bile duct. These are the cells of the liver. And on regular conditions, when the patient is is healthy, there's always some sort of balance between the liver and the bile duct and the gamma GT in the blood. This is the blood. But once there is an injury to the bile duct, then there's increased gamma GT that goes into the liver cells, and this actually causes increased gamma GT in the blood. This signifies that there may be some injury to the bile ducts. Of course, if it's already diagnosed PSC, we follow up on the gamma GT, and this is a good marker for disease activity. Gamma GT can also be elevated when you drink alcohol and various drugs, but this is mostly in adults and not so much in kids. So going back to the paper that was published 3 years ago, when we looked at gamma GT, and we saw that in the group of patients, this is a graph that shows who survived or who had complications through the years, and the upper graph shows you the kids who gamma GT decreased, and the lower graph shows you the kids who gamma GT were not decreased or elevated. So you can see here that when gamma GT was lowered through especially first year, there were less complications and kids survived better. Whereas if gamma GT did not decrease significantly, then there were more likelihood to have complications. This is very important because this is served us now as a good marker and a good aim to decrease the gamma GT, hopefully to provide better prognosis for the child. So how do you decrease gamma GT? Sometimes you just don't need to do anything and it decreases by itself, but sometimes you need to give therapy. So as I told you, ursolite or ursodiol is an important treatment that we used to give, and the kids that we gave ursodiol and gamma GT decreased, they have good prognosis. As you can see here, the line did not go down significantly, meaning they didn't have significant complication. Whereas in the group that did not, the gamma GT did not decrease, then they presented with significant complications. Later study was published in the Journal of Pediatrics, which is a very important journal in the pediatrics world. We compared the ursodeoxycholic acid treatment in kids and you can see that if you treat a child for a year with ursodiol, 50% of the kids have normalized gamma GT, and these kids actually have better prognosis and they have less complications. Unfortunately, in kids that have Crohn's, it's less probable that they will decrease the gamma GT with treatment of ursodiol, and therefore now we try to give all kids ursodiol or ursodeoxycholic acid, and if we succeed in reducing the gamma GT, then we continue. If after a few months the gamma GT is not decreased, then we just stop the medication, remembering the possible side effects of the ursodiol. But this paper showed that even if we did not decrease the gamma GT totally, and even if it's still a little bit high, then there's still better prognosis than if you don't decrease at all the gamma GT. So it's not really all or none. If you tend to decrease the gamma GT in some way, then you provide better prognosis for the children. So this is regarding the treatment. So unfortunately, there's not a good treatment today for kids or for adults. So we choose a treatment regarding how they react to ursodiol, and still waiting for new medication that hopefully I will show you later what's in line. The other thing that came out of our consortium is is a prognostic index or prognostic tool for children. What does that mean? It means that we take few labs like bilirubin, albumin, platelet counts, gamma GT, which I showed it's important, and how does the imaging looks. If in MRCP or ultrasound there's bile duct involvement, then it's important. And we put them all in calculation. And then there's a score. I'll show you just an example of a child. If a child, for example, have a bilirubin of 0, which normal bilirubin, he gets 0 points. If he has albumin of between 32 and 39, which is a little bit lower than normal, he gets 1 point. If his platelet counts is above 225,000, which is actually normal, he gets 0 point. And if the gamma GT is normal, he gets also 0 point. So for this child, if you sum up his point, he gets scope 2. Scope is the index of cirrhosis, cholangitis outcome in pediatrics. So you turn to this table, and the table has 3 risk groups: the low risk group, the medium risk group, and the high risk group. And you can see here, according to the scope index, you can see what is the likelihood of a child to have complication in the first 5 years after the diagnosis, and what is the likelihood of a child to be transplanted in the first 5 years. And in our child that I just told you about, his scope index is 2. So there is a very low likelihood of this child to undergo liver transplant. As you see, after 5 years, there's 2% of him having a liver transplant. Having complications increase more through the years, and after 5 years, if you have scope index of 2, you have 9% of likelihood of having complications. So this is about the score. Do we do it? Actually, I don't think you should do it, and I usually don't tend to do it, especially don't tell the parents, because it doesn't really matter what is the statistics about your child. You should look at your child and assess him and be happy with what he has, and not go through statistics and think about what will happen in 5 years. So what the future holds for us. So maybe some of you know this website of the NIH in the US, that is clinicaltrial.gov, which in this site you can find any study that goes around the world regarding any disease. So if you look at cirrhosis, cholangitis, and pediatrics, you can see there is about 6 studies throughout the world that are registered in the NIH, which is not a lot. But if you look at the adult, and I think most of the children actually are being diagnosed around teens, so they don't have a lot of years until they become adults. So there is about 76 new studies that are going on now about PSC in adults. So there is hope regarding more information and more potentially new drugs for treating PSC. I want to tell you some aspects about treatment or possible treatments of PSC that actually started from pediatrics. It's really rare to have studies that begin in pediatrics and then go to adults. So Albireo company has a treatment for decreasing bile acids in the blood. And here we hear, and some other centers in the world are also already been involved in several studies of this drug in other diseases like PFIC, biliary atresia, and allergy, which are other cholestasis diseases that the children have. And this medication has really changed the course of the disease and reduced pruritus, which is one of the complications of PSC also, and lowered the levels of bile acid in the blood, hoping in the future it will improve the liver injury. So this company actually promised us to start study on other cholestatic diseases. Some of the study will include PSC. So this is hopefully in the next year or so will start. And in adults also, they plan to use the same drug in adults with PSC. Another company that actually started also from children is Mirum, and also has a drug that's a little bit similar to Albireo that already started on Alagille syndrome, has very good results on Alagille syndrome, which also cholestatic diseases. And the next step is primary sclerosing cholangitis in adults. So there is a future, and there is hope for new medications for PSC. So in conclusion, although PSC is chronic and progressive, slowly progressive disease, only 30 to 40% of the children develop adverse liver outcome after 10 years of the diseases. It's not few, but it's not a large percentage. Children have better prognosis than adults, and they usually, our aim in children is to bring them to adulthood, meaning we aim to give them good quality of life, and most importantly is to have them grow and thrive as best they can, so they reach their height and reach their weight when they become adults. And hopefully when they become adults, they get new treatment for PSC. And as I told you, there are multiple drugs that are being developed as we talk, and hopefully soon to be given to you and your families. So this is the center that I'm working in Shaare Zedek. This is the mountain of Jerusalem. And I send you warm regards from Jerusalem, and I hope you learn from this talk, and I'll be happy to answer any questions.
Hi everyone, I'm Natasha. I'm a PhD candidate and gastro trainee from Melbourne in Australia, and I'd like to thank the European Liver Patients Association for inviting me today. These are my disclosures. As we know, primary sclerosing cholangitis is an uncommon chronic cholestatic liver disease. It manifests as multifocal areas of bile duct narrowing due to chronic inflammation and fibrosis, mainly affecting males with a median age of onset at 30 to 40 years. As we've heard from our previous speakers, there is a significant association with inflammatory bowel disease, hepatobiliary cancers, especially cholangiocarcinoma, and colon cancer, especially in those with inflammatory bowel disease. There is no effective medical therapy to date to alter the natural history of the disease, but we do have an effective therapy of liver transplantation with a high 5-year survival of up to 85%. A little bit about Australia for those who don't know it very well. We have a population of 25 million people. 44% of the combined capital city population are made up of people aged 20 to 49, and an almost equal gender ratio of 98.2 males to 100 females. Life expectancy at birth is 80.9 years for males and 85 for females. And we have a diverse ethnic background due to immigration from European countries, and more recently, Southeast Asian and Asian countries as well, as you can see. What do we know on PSC in Australia at the moment? There has been 2 published retrospective cohort studies based out of New South Wales and Victoria. Lewin and his colleagues from New South Wales studied 208 patients from Sydney Local Health District, serviced by 2 tertiary referral centres, one being a referral transplant centre. Half of the cohort was cirrhotic, with 29% undergoing liver transplantation during the study period. 41% of patients died or had a liver transplant, and the median transplant-free survival was 11 years. Death without transplant occurred in 12% after a median of 23 years. They also looked to compare the differences between patients with PSC only and patients with PSC and inflammatory bowel disease. As you can see from the Kaplan-Meier curve on the right, even though it looks like the curves are different, the p-value was 0.43, which did not show any statistical significance between both groups. A colleague of mine, Freeman et al., looked at 39 patients from a single tertiary non-transplant referral center with also very similar clinical characteristics and demographics to North American and European PSC patients, and also the cohort from New South Wales. 8% of patients develop cholangiocarcinoma after a median time of 53 months from diagnosis. 13% were cirrhotic at diagnosis, and 26% developed cirrhosis after a median of 54 months. This cohort did quite well with 5, 10, and 20-year transplant-free survival rates at 86.5%, 77.4%, and 68.8% respectively. So I'd like to take the opportunity to share some of our results from our multi-center cohort retrospective study that we've expanded on since presenting at Australian Gastroenterology Week last year. So this is a cohort study across 9 tertiary referral centers in Melbourne, Sydney, and Adelaide, consisting of 2 transplant referral centers. We included all adult patients with a diagnosis of PSC, and we looked through all the case reports to rule out patients with secondary causes for sclerosing cholangitis and to make sure there were no duplicates. Our aims were to describe the natural history, demographics, clinical characteristics, and long-term outcomes of patients with PSC in Australia. We also aimed to compare the survival of PSC patients in Australia to that of the general population, stratified based on age cohorts and decade of diagnosis. We also looked to identify any predictors of outcomes or trends that are unique to that of the Australian PSC cohort. Our primary endpoint was that of time to death or liver transplant, and our secondary endpoints were as discussed previously. So looking at our results, we managed to collect a total of 525 patients with a mean age of 35 years. Majority of the cohort were male at 64.8%, and 58.7% of the cohort were initially managed at a liver transplant unit. As you can expect, majority of patients were Caucasian, 89%, 5.7% of the cohort were Asian, and other ethnic groups constituted of the rest. Looking at the clinical characteristics, they were very similar to North American and European cohorts. Majority had large duct PSC at 89.7%, 83.8% did not have evidence of overlap syndrome, and inflammatory bowel disease was present in 71.2%. Of those, majority were diagnosed with ulcerative colitis. Ursodeoxycholic acid use was prescribed in 62.7% of the cohort. 27.4% of our patients had a dominant stricture, which is defined as a narrowing of the bile duct of less than 1.5 millimeters in the common bile duct, or less than 1 millimeter in the common hepatic duct. We also had quite a high proportion of patients with cirrhosis at 47.6%, and out of those with cirrhosis, 81.6% had concomitant portal hypertension. In terms of the presence of malignancy, 5.9% of our cohort had cholangiocarcinoma, 4.6% had hepatocellular carcinoma, and 3% developed colorectal cancer. Out of the 16 patients who had colorectal cancer, 14 of them had inflammatory bowel disease as well. We did collect all liver biochemistry, but thought I'll bring your interest to alkaline phosphatase, which is a marker of cholestasis and also used as a surrogate endpoint in many clinical trials. Our median ALP at time of diagnosis was 293 international units per liter, and this seemed to improve with follow-up down to 194, with a mean change of minus 265. And looking at the graph on the right, there was actually no difference in change in alkaline phosphatase in patients taking ursodeoxycholic acid and compared to those who did not. Whether this is an issue with adherence, dosing, or whether it truly just reflects the natural variability of ALP and PSC, it's unclear at this stage. And then we looked to compare the groups based on when patients were diagnosed. So we divided the cohorts into patients who were diagnosed from 2000 to 2009, and those who were diagnosed from 2010 to current day. And as you can see highlighted in the graphs, patients who were diagnosed more recently were older, with a median age of 38 compared to 32, and otherwise very similar demographics. Other differences include more patients being diagnosed via an imaging modality in recent times, 61.2% were diagnosed by MRI or CT compared to 44.6% in the earlier decade. Less patients had inflammatory bowel disease in the more recent cohort, 66.1% compared to 79%. And also there was less colorectal cancer and cirrhosis, but it is likely due to the reduced follow-up time and length of disease in the later cohort. This is a heat map describing the relative survival of PSC patients to the general population, and we're looking at patients diagnosed from 2000 to 2010. So each box in red represents comparable survival compared to the general population, and as the color fades to white and blue, that describes reduction in relative survival. And you can see quite clearly that with increasing age of diagnosis, there is reduction in relative survival. For example, if you were diagnosed at 30 years of age, you would have comparable survival to the general population up to 16 to 18 years from diagnosis, as compared to someone who was diagnosed at 60 years of age. Your relative survival will drop to 59% after 10 to 12 years from diagnosis. Now looking at this heat map for patients diagnosed after 2010, this seems to be exaggerated with relative survival dropping even after just 4 to 6 years from diagnosis. However, there is a clear trend that increasing age from diagnosis does have a significant impact on survival. So looking at the whole cohort and the risk of death or liver transplant. So 15% of our cohort passed away during the study period, 36.8% died from cholangiocarcinoma, and 22.8% died from end-stage liver disease. A quarter of the cohort had a liver transplant and 9.6% required retransplantation. So the Kaplan-Meier curve on the left shows the risk of death for liver transplant, and it took a median time of 15 years from time of diagnosis to our primary endpoint. Interestingly, when you divide this based on whether you were managed at a transplant center or not, with the green line being describing patients from a transplant center and the blue line describing patients who are from a non-transplant center, you can see quite clearly that the median time to death or transplant is decreased if you are managed in a transplant center at 14 compared to 24, and this was significant. And this is more likely a result of referral bias, as patients who are more sick and have evidence of more advanced liver disease are more likely to be managed at a transplant center. So looking at the risk of death or liver transplant based on period of diagnosis, as we alluded to in the heat maps before, patients who were diagnosed at a later point in time, so from 2010 to present, seem to reach the endpoint sooner compared to patients who were diagnosed from 2000 to 2009. Now looking at the risk of cholangiocarcinoma, the median time from diagnosis to development of cholangiocarcinoma was 7 years. And it was found that patients with a dominant stricture were more likely to develop cholangiocarcinoma. So looking at the bar graphs at the bottom right, so if you had a dominant stricture, patients who had a dominant stricture, 12.5% of them developed cholangiocarcinoma compared to only 3.4% of patients without a dominant stricture. And your odds of developing a cholangiocarcinoma is 3.3 times higher compared to those without the dominant stricture when we adjusted for age of diagnosis, gender, subtype, whether or not you had MRI surveillance, and even the presence of inflammatory bowel disease. There was no difference in frequency of cholangiocarcinoma or time to cholangiocarcinoma when stratified by age of diagnosis. We also looked at predictors of death or liver transplantation, and not surprisingly, the presence of cholangiocarcinoma increased your risk of death or transplant by 6 compared to other patients, and the presence of cirrhosis increased this risk by 3. So in summary, this is the largest retrospective study of PSC patients in Australia that we're currently writing up our manuscript for submission, which describes similar demographics and clinical characteristics to other Caucasian cohorts. The development of cholangiocarcinoma and cirrhosis are risk factors for death or liver transplant. And we found out that the risk of cholangiocarcinoma is increased in patients with dominant stricture. There is a comparable survival to the general population in the early years of disease. However, this survival is reduced with increasing age of diagnosis. We have noted an interesting trend to earlier liver transplant and death in patients diagnosed in the last decade. This may be related to a delay in diagnosis, resulting in patients diagnosed at an older age, or it may reflect misdiagnosis in early years with a long disease lag time, or it just might reflect a more aggressive disease biology in recent times in older patients with less concomitant IBD. We acknowledge the limitations of our study with selection bias with sicker patients who were diagnosed early, perhaps not being captured in our data, and most hospitals only having electronic medical records from year 2010 onwards, affecting quality of older data collection. Hence, we are conducting an ongoing prospective cohort study on PSC patients across Australia and hoping to expand the number of sites as well. And strengths will include data linkage with national registries, serial disease predictive scores that are measured over time with the enhanced liver fibrosis score and MRI elastography. We're also aiming to collect biosamples across the years for storage and analysis. And we also like to compare our clinical findings with that of health-related questionnaires for patients with PSC and IBD as well. I'd like to acknowledge my supervisory team and the participating hospitals as well for contributing to this study and our results. And thank you everyone for listening. If there's any questions, feel free to email me, or if you would like to collaborate for this project, feel free to email me as well. Thank you.
Hello and welcome to Oslo, Norway. I am Johannes Hov. I'm a professor and a consultant in gastroenterology, and I'm working here at the Norwegian PSC Research Center in Oslo. And this research center, No PSC, it was founded in 2007, and but research on the disease PSC has been going on here since it was. I think the first good descriptions of the disease were made in late 70s, actually. So we have a long history of PSC research. Currently, we have a very active agenda. I think we are 20 to 30 researchers actually involved in what we do. And we focus on the disease, and actually all aspects of the disease are of interest to us. And we also want to support research on PSC worldwide to the degree that we are able. Still, there are some main points I think that we're interested in, and one of the things is research on clinical research related to how we can measure the disease. Because one of the challenges that we have when we care for the patients is that it's very hard for us to measure the activity of the disease and to say something about the prospects of the disease. So we're interested in biomarkers. What can we measure in blood that tell us something about the disease and the activity and what kind of treatment it should have, for instance. Another big clinical problem, perhaps the biggest of them all, is how we can diagnose cholangiocarcinoma. And we have an active group here working on trying to find new ways. For instance, is there something in the bile that we can look at? Are there genetic or epigenetic changes in the bile that we can measure early before we can see the cancer? This would help us a lot, because then we could potentially treat or transplant patients earlier. And then we have a few groups that are trying to work more into aspects of the pathogenesis or the disease mechanisms. We have one large group working on experimental models and liver immunology. Because is it possible to find immune cells or parts of the immune system that are somehow is active during inflammation of the bile ducts? And is it possible then that we can modify these specific immune cells to treat the disease more efficiently? So this is of course on a more basic level, but the idea is of course to identify new opportunities that we could translate into the clinic. We also want to, we try to gather as much material, biological material, from the patients, participants that want to take part in our research. We have a very large biobank, and one of the things that this experimental group is working on is to isolate and grow bile duct cells from the individual patients, and hopefully we can make them grow small, like mini organs, like mini bile ducts, and because then we could perhaps understand in detail, for instance, how a specific drug could act on the bile duct cells from a specific patient. So these are organoids and organs on a chip that we like to call it. And these are very exciting areas of research, but of course there is still some time before we will see any clinical impact of it. And then finally we have the group that I am leading, where our particular interest is what's going in the gut, because I think PSC is really a disease of the gut and the liver. And is it possible that all the bacteria and all the microbes in the gut, they together, they constitute like a biochemical factory? And is it possible that the products of this biochemical factory somehow could be causing or at least driving the disease, and could we potentially change it, alter it, improve it in a way that could improve the disease? So these are, in a few words, the totality of what we are interested in here at the PSC Research Center in Oslo. And I must say that our aims ahead now, we have been working for years, but I must say our main aim now is really to try to think about all the projects we have and see, is it possible to make this clinically relevant? Can this make a clinical impact? So it's challenging, but hopefully we can do this within not too many years. So thank you very much for your attention, and best of luck with the PSC Awareness Day. Thank you.
I would like to thank all the people that took time today to be here with us, and all the experts who explain what PSC is and the impact that it has in people and children around the world. Nothing about rare diseases is simple, not the diagnosis, nor the daily care, not the long term. When you have a rare disease, you face two battles, one being the illness itself, and the other living in a world where so few people understand what you are up against. Stay aware, spread awareness, take action. A disease may be rare, but hope should not be. Together, we are stronger.